One of three of head and neck, and this is the last exam for NGA of this semester. So I'm Stacy Hunter at Lincoln Memorial University DeBusk College of Osteopathic Medicine, and some of these slides are from Allie. Okay, so we're going to start with the skull and look at just the main features of it first. So we've got the cranium. It is the skeleton of the head. It's composed of two parts. So we've got the neurocranium and the viscerocranium. The neurocranium is the bony case of the brain, and then the viscerocranium are these facial bones. The neurocranium is further divided into two parts. So we have the calvaria, which is the dome-shaped roof of the neurocranium, and then we also have the cranial base, which is the floor of the neurocranium. The majority of these bones are going to be fused via fibrous sutures, which you can see some right here. So we're going to go ahead and name them. So in the very front right here, we've got a coronal suture. So if you think of putting on a crown, that would be coronal. As we go back, down the head is the sagittal suture, down that sagittal line. And then in the back is the lambdoid suture. So there are two parts where the sagittal suture meets up with another suture. So in the front, the sagittal suture meets that coronal suture at the bregma, and in the back, the sagittal suture meets the lambdoid suture at the lambda. So lambda and lambdoid. That can help you remember it. And you can see it back here as well. On the lateral aspect of the skull, you can see the squamous suture. And as the squamous suture and the coronal suture are meeting up, we've got the pterion. Okay, so let's look at the anterior skull. So right above the orbit, we see the supraorbital notch. Here's our frontal process. And then as we continue on down and go down the ethmoid, then we go to the lower portion of the orbit, and that is going to have our infraorbital foramen, and you can see it labeled here on this side. Here's our maxilla. Right in the middle of our nose is going to be the vomer. That's going to be the bony portion. On our mandible, we've got two openings, which are the mental foramen, and we're going to talk about what runs through them later on. And then the bottom of our chin is the mental protuberance. Okay, so let's look at the skull base grooves. Now we're going to be talking about later the sinuses that travel through this, but we're going to go ahead and label them now, and then we'll see them again in a few minutes. But first off, there's going to be an impression in this skull where the middle meningeal artery is going to travel. We're going to talk about that with injuries and epidural hematomas, where it can rupture this middle meningeal artery and cause a hemorrhagic stroke when there's any force to the pterion. So right here is the carotid sulcus in the sphenoid. Right here is the tegmen tympani, which is the roof of the middle ear. And right here we've got labeled the lesser wing or sphenoid. So over here we've got our sinuses labeled. So this is the superior sagittal sinus. As it comes down to the star, that's going to be the confluence of sinuses at the internal occipital protuberance. As we continue on around in light green, we've got the transverse sinus, continuing to the sigmoid sinus, making that S shape. And then right here in light blue is the inferior petrosal sinus, and then here is the cavernous sinus. So the skull base foramina, a really good just 3D run through of this is found on this YouTube link, but another way of remembering it is through this story, which I think is pretty fun. So Clive, the Turkish cowboy, is searching for his girlfriend, Krista Galley. And so here's Krista Galley, because she has dinner on a plate, cribiform plate, waiting for him. He rides his horse with a Turkish saddle, so that's sella turcica, with his feet nestled in the superior orbital fissures. And his lasso, foramen lucera, hanging right beside him. Clive rides through the tundra, foramen rotundum, and looks out over the valley, foramen ovale. So foramen rotundum, foramen ovale. and he spits foramen spinosum out of piece of meat, internal acoustic meatus, into a jugular foramen. So we've got foramen spinosum, we've got the internal acoustic meatus, and then the jugular foramen. Another way that really helped me of knowing what travels through what hole in the skull is this YouTube video that goes through everything, and it gives you some really great mnemonics. It's like, for example, we have our foramen ovale. If you spell out ovale, it helps you know what goes through it. So optic ganglion, V3, trigeminal, A, accessory meningeal artery, L, lesser petrosal, E, emissary veins. And so it helps remember all of this stuff again. And so that V3, again, that was that standing room only. And we'll talk more about that in a little bit. Okay, so here's some more of this inferior skull and the things that go through it. Just make sure that you're really familiar with this. Okay, so there are 3 types of fractures. We've got Lefort 1, 2, and 3. So Lefort 1 is characterized by that dislocation of the alveolar process of the maxilla and involvement of that piriform aperture. So as you can see, it has a fracture right above that maxilla. Lefort 2 are moving that fracture on up, and it's involving the inferior margin of the orbit. And so sometimes there might be involvement of the cheek as well. So you can see this as it goes through along the bridge of the nose and back down. Lefort 3, like you would think, it would be even higher. And so it's going right through the middle of that orbit, characterized by that fracture of the zygomatic arch, and cerebrospinal fluid may actually leak with this one. So here's our sphenoid and temporal bones. So here is the body of the sphenoid. And so here's the pterygoid hamless. Here's this canal for the auditory tube, and here's the pterygotympanic fissure. So you can go ahead and look at all of these and label them. Okay, so now we're going to talk about the meninges and cranial circulation. So we're going to talk about aneurysms, specifically talk and die syndrome, shaken baby syndrome, and then berry aneurysms. And then we're going to go through and talk about dural partitions and innervation, and then we're going to go through the CSF and the venous sinuses. So let's first talk about the meninges. First the spinal cord, and then go along and talk about the brain. So they're very similar, but just slightly different. So first we've got that dura mater on the outside, and that's our first meninges that we come to, and it's that tough mother, the outermost layer. Then we're going to have the arachnoid mater, which is going to be the spider mother, and it's thin, delicate, and avascular, and it's adhered to that arachnoid mater, or to the dura mater. The pia mater is the tender mother, and it is like saran wrapped basically to the cord. And so that would be something that like is hard to get off when you're looking in lab. It's directly on that cord. So the first space that we come to is the epidural space, and that's that space above the dura mater, and it's containing fat and internal vertebral venous plexus, so therefore it is a true space. The next space is the subdural space. It's a potential space. There's nothing located there, so if something does accumulate, like blood or fluid, that may be a potential problem and put pressure on that spinal cord. Our last layer is the subarachnoid space in between arachnoid and pia mater, and it is a true space. It's filled with cerebral spinal fluid, so when doing a lumbar puncture, this is where that you would gain access to that CSF. In the brain, it's slightly different but very similar. So here's our dura mater, just like we had in the spinal cord, but this time it's got 2 layers. We've got a periostesial layer and then a meningeal layer. So the meningeal layer is continuous with that cord dura, like we had talked about earlier. So here's this one, and then here's our next layer. So the arachnoid mater is loosely attached to the dura, and it's containing those arachnoid granulations that we're going to be talking about. And they absorb that CSF. Our last layer is the pia mater, which is just that saran wrap again to the brain this time. So we said the epidural space within the spinal cord was a true space. However, on the brain, it is now a potential space. So there's no epidural fat or venous plexus. So if something like blood were to accumulate, this would cause a major problem. Subdural space, again, is a potential space, and then the subarachnoid space is a true space containing CSF. So let's say somebody's playing football, they hit their head, the brain is not directly against the skull. It's got a little wiggle room, so it's able to move. So if force does come upon the head or the brain, it's able to move a little bit. Okay, so let's talk about aneurysms or hemorrhagic strokes that are involving these spaces. So the first one that we have is in the epidural space, and remember that epidural space in the brain is a potential space. So if there is a blow to the head at the pterion, there could be a rupture of the middle meningeal artery. And so a patient would present with a blow to the head, and they're talking normal, and they're like, I feel fine. And they go along with their day, and suddenly they drop dead. And so this is because it's a slow bleed, and it's pushing on that dura mater, and it continues pushing and growing until it is pushing too much on the brain. So there's no direct blood on the brain. However, there is blood in between the dura and the skull itself, and it's therefore pushing on the brain. So in this CT, you can see this white. Anytime that you see bright white is going to be blood. And so you see this white making a lemon or a football shape. So that is an epidural hematoma in between the dura mater and the skull. So the next layer is our subdural space, and so it's a potential space again. And so if there's a rupture of the bridging veins within that dura, they're like an example would be shaken baby syndrome or like shaken elderly person syndrome. It's rupturing those veins, and so therefore they get that crescent moon shape, as you can see right here, and that is under the dura. Next, we get the arachnoid meninges, and under that is the subarachnoid space. Now, remember, that is a true space, and this contains the CSF as well as the circle of Willis that we'll talk about. And so the circle of Willis is some arteries that are on the brain and supply the brain. So if there's a rupture of one of these or an aneurysm, and the aneurysm kind of looks like little berries, and so a patient would present with the worst headache of their life. So you do a CT of the head and you'll see something like this. So you see that it's not like the epidural subdural on the outside, it's kind of in the middle and more diffuse. Okay, so let's talk about the dural partitions. So we've got this falx cerebri located here at the top. As we go down to our cerebellum, we've got the falx cerebelli. So the falx cerebri is between the cerebral hemispheres, while this falx cerebri is in between the cerebellar hemispheres. The tentorum cerebelli is like a little tent located over top of the cerebellum, and it's below the occipital lobe. So our dura actually has innervation, and in OPP you actually learn some manipulations to be able to move some of that CSF and to provide some relief, let's say if somebody has a headache. So some of this could be because of one of these nerves are being sort of impinged. So the anterior and middle cranial fossa are innervated by cranial nerve 5, which is trigeminal, and then the posterior cranial fossa is innervated by cranial nerve 10, which is vagus, as well as cervical nerves 1 through 3. So a way you can remember this is 5 plus 5 equals 10. So the flow of cerebral spinal fluid goes from our first two ventricles, which are composed of our lateral ventricles, to our third and then our fourth. But it's important to know what doors they go through. So we have our lateral ventricles starting right here, and they go down through that interventricular, so between the ventricles, foramen of Monroe. From there, we go to our third ventricle, right at the level of the thalamus, and then it's going to exit via the cerebral aqueduct into our fourth ventricle. And then our fourth ventricle, at the level of the pons and the medulla, is going to exit via the foramen of Luschka and then meninges. So Luschka is more lateral, meninge starts with an M, it's more medial. From there, we go to the subarachnoid space into those arachnoid granulations that we had talked about, and then the superior sagittal sinus. So if there's too much CSF, for example, in a baby, it can lead to hydrocephalus, which is leading to this macrocephaly, so big head. Hydrocephalus can also happen in adults as well, but their heads are not going to be able to swell. So babies, their sutures haven't fused yet, so they're able to compensate for this extra fluid, and so their skull expands. However, adults, where it's already fused, this increase in production is going to cause major problems, causing cerebral edema. Okay, so let's talk about the dural venous sinuses. So we've got this superior sagittal sinus that goes on the upper portion of the falx cerebri, and then on the lower part, we've got the inferior sagittal. From inferior sagittal, we've got the straight sinus going down to meet up with the superior sagittal at this confluence of sinuses. From there, we go to the transverse in the tentorium cerebri, draining from the confluence into over to the sigmoid sinus, and then that is going to go into our jugular foramen. So right here we can see it. We've got the superior sagittal and then inferior sagittal going to straight, as well as that great cerebral, and then occipital, and it's all draining in the confluence of sinuses that's going to transverse to sigmoid out the internal. Now, these that were harder to see in the picture, but you can probably see in the model room, are the cavernous sinus going to superior and inferior petrosal, draining into the internal jugular. So this area is called the danger triangle, which is composed of your nose and maxilla. And what happens is this area usually drains into the facial vein, which then goes to the internal jugular, but instead it may go to the ophthalmic veins and end up in the cavernous sinus, which can then go to the brain and cause a major issue. So we've got the contents are going to be the internal carotid, as you can see right here, and then the nerves to the eyes, 3 through 5, V1 and V2. So let's look at them in the picture. We've got cranial nerve 3, cranial nerve 4. Right here is V1 and V2. So as you might suspect, and here's abducens cranial nerve 6. Cranial nerve 3, 4, and 6 all go to the eyes. And so we may have blurry vision or an eye problem as well. And so if there's a major issue, this could cause blindness. Okay, so let's talk about the circle of Willis. So the actual circle of Willis is going to just be this circle right here. But typically when we talk about the circle of Willis, we're talking about all of the other arteries as well going to our brain. So let's start at the top. We've got anterior cerebral. So it's going down and kind of around. So it goes pretty far. It goes farther. Even after it meets up with another artery, it continues on. Then we've got anterior communicating, and it's communicating between these branches of anterior cerebral. anterior cerebral meets up with the internal carotid, and that's what this artery is right here in that fuchsia color. And remember, internal carotid came from common carotid. To the middle portion of the brain, we're going to give off a branch, which is middle cerebral. So we had anterior and middle. We're also going to have posterior cerebral, but it is not meeting up with internal carotid. It's actually back here, a little bit farther away. But to complete our circle, we're going to have a communicating branch, so that's posterior communicating. So to make the actual circle of Willis, it's anterior cerebral, meeting up with the internal carotid, and posterior communicating, meeting up with posterior cerebral. And then finishing that up at the front is anterior communicating. If we continue on down, we go down this larger artery, which is the basilar artery. And our first branch off of it is going to be the superior cerebellar. So in the front, we were talking about cerebral, and now we're down to the cerebellum. So this is superior cerebellar. Like you might think, if there's a superior, there's probably an inferior. So as we continue down, there's going to be first the anterior inferior cerebellar artery. So for short, we call that ICA. As we split from basilar, these become the vertebral arteries. And remember, vertebral came from subclavian. So we said the arteries coming from the subclavian was vitamin C and D, VIT, C, and D. So the V is vertebral. And so it's coming up to supply our head. And so we've got that branches of the basilar, and coming off of vertebral is our pica, so the posterior inferior cerebellar. So remember that pica comes off of vertebral, however, anterior inferior cerebellar, ICA, is coming off of the basilar. We have one more branch down the center coming off of vertebral as well, and that's going to be anterior spinal. And that's getting the anterior portion of our spinal cord. So here is just another way to look at it, and I think it looks like a lobster, kind of. And so there's a few extra arteries that are labeled on this diagram, and so I'm going to talk about them really quick. So we've got, here's our internal cerebral artery. So we said that we have internal carotid, but we said anterior cerebral came off of this internal carotid artery, and as well as middle cerebral, and then posterior communicating. But we've got two more, so there's 5 coming off of this. So we've got hypophyseal arteries, and that's going to our pituitary stalk, and then we have ophthalmic artery going to our eyes, and that's a really favorite one to tag on practicals. We also have pontine arteries coming off of that basilar going to our pons, and then since we had anterior spinal, we also have posterior spinal. Now don't worry about these syndromes. You're going to learn these in neuroanatomy, but they're just here for completion's sake. So here's just a blank copy that you can go ahead and print out if you want, and then you'll be able to draw this on your own and be able to know it. And labeled are the parts of the brain. So here is looking at this on the actual brain as well as on a CT. One thing that I did not mention, so I'll go back real quick, is the relationship between cranial nerve 3 and cranial nerve 6. So as you can tell, cranial nerve 3 is very close to posterior cerebral and superior cerebellar. So it's going in between these. So let's say that there is a berry aneurysm and it's pushing on this nerve. Well, cranial nerve 3 is going to the eyes to provide motor function. So if somebody is starting to have an eye that's turned down and out, that might be an indication that there is an aneurysm that's either ruptured or pressing on this nerve. This nerve is cranial nerve 6. And so that makes your eye go outwards. So if move laterally, so if there was a lesion or for example, a aneurysm pushing on that one, the patient's eye would turn more medially. And we're going to talk more about that when we get to eyes. So here's that cranial nerve 3 again, between that posterior cerebral and that superior cerebellar. Here's that internal carotid. You can kind of barely see anterior cerebral. Here's the posterior communicating. And just be able to also label it on a angiogram as well. Here's the MRI, a transverse section. So you can see this line that goes all the way out. So that's called the central sulcus. And then in front of it is going to be precentral gyrus. And then the postcentral gyrus is behind it. And you're going to learn the importance of these gyri when you get to neuroanatomy. Here's a CT of the head, a coronal view. So right here in number 1, we've got that falx cerebri that's coming down. As we look on the CT, we can see the lateral ventricles. As they continue on down, we go to the third ventricle. And then this one I think is a little hard, but that's the basilar artery. So let's talk about the cranial nerves. So one way of remembering it is O, to touch and feel very good velvet of heaven. I think that one's a little bit hard, but I do think that this second mnemonic is pretty good. So this tells you if it's motor, sensory, or both, and all you have to do is just number it. So 1, 2, 3, 4, and so on. So some say marry money, but my brother says big brains matter most. So if it starts with an S, then it's sensory. If it starts with an M, it's motor, and if it starts with a B, it's both of them. So let's look at all of the cranial nerves. So we'll start first with just the numbers and the names. So number 1 is olfactory. 2, and that's going to give our sense of smell. 2 is optic, and that's going for vision. 3, oculomotor, and that's giving us a ability to move the eye in most of the directions except 2. So we'll talk about the other 2 eye ones, which is 4, trochlear, and then 5, abducent, or 6, abducens. So all 3 of these are going to be our eye cranial nerves. And then cranial nerve 5 is trigeminal. Cranial nerve 7 is facial. Cranial nerve 8 is vestibulocochlear. So cochlear, hearing, and then vestibule is going to be equilibrium. And so a word that's kind of familiar to some people would be like vertigo. And so that would be where your equilibrium would be off. Cranial nerve 9 is glossopharyngeal. Cranial nerve 10, you already know, vagus. Cranial nerve 11, also you already know, that's going to be spinal accessory. And then our last nerve is going to be the hypoglossal. So I had a hard time remembering what are between 9 and 12. And so these are actually in alphabetical order, so that can help you. Make sure that you know the name as well as the numbers. So you might say, oh, well, I know that that cranial nerve 3 does all the actions to the eye except 2, but I didn't actually know that it's oculomotor. So that might cost you some points on the test. And usually they'll just refer to it by either just its name or by the cranial nerve number, but not both. So just make sure that you know those names. Okay, so let's talk about where they exit. So the olfactory is going to be exiting at that cribiform plate that we talked about with crista galli in the middle. The optic nerve, really easy, optic canal. Now let's talk about 3, 4, and 6. They're all going to the eye to produce movement. So the superior orbital fissure is where they're all exiting. The trigeminal nerve, we're going to talk more about it, but it's standing room only. So superior orbital fissure, foramen rotundum, and foramen ovale. Then cranial nerve 7 and 8 go through the internal acoustic meatus, and then facial continues on through the stylomastoid foramen. Cranial nerve 9 through 11 goes through the jugular foramen, and then hypoglossal nerve gets its own hypoglossal canal. So a great way of remembering what these guys do is by knowing what a lesion to them would be. So if I lesion cranial nerve 1, I'm going to have anosmia, which just means if we put A, it means not. So no, and then nose, it sounds like nose. So no smell. If I cut cranial nerve 2, I'm going to have blindness, and I'm not going to have peripheral vision. If I cut my cranial nerve 3, my eye is going to be down and out like I had talked about earlier. Your eyelid is going to be drooped because it's going to also innervate the levator palpebrae superioris, which is, levator means up, palpebrae means eyelid, and superioris is the top one. So raising my eyelid is what it does. So it's going to droop if it's cut, if cranial nerve 3 is cut. I'm not going to be able to constrict my pupil since oculomotor also goes to constrictor pupillae, and then I'm going to have trouble with accommodation, so I'm not going to be able to read something up close, and that is an action by the ciliary body. Cranial nerve 4, it does superior oblique, so a problem with that would be double vision, and so make sure that you know that. Cranial nerve 5, I'm going to have facial pain and trouble chewing because it helps with mastication and sensation of the face. Cranial nerve 6, I'm going to have a medial strabismus, so my eye is going to look in because cranial nerve 6 goes to the lateral rectus, and don't worry, we're going to talk more about these muscles, but it's moving my eye out more laterally, so if it's a lesion and I can't do that, my eye is going to look toward my nose. The facial nerve does facial expression as well as provides motor function to the submandibular, sublingual, and lacrimal glands, and then also provides sensation to the anterior 2/3 of the tongue and soft palate. So I can't close my eyes, smile, wrinkle my forehead, and I have ptosis, and we'll talk more about what ptosis means. But that is going to result in something that looks a lot like Bell's palsy. Vestibulocochlear, I'm going to have hearing loss and dizziness. Glossopharyngeal, I'm going to have difficulty swallowing, and there's not going to be a gag reflex. So if you were to put something and tell somebody to say, ah, and you put one of those sticks in their mouth that helps them make their tongue go down, it sometimes gags them, and so they're not going to be able to do that with loss of glossopharyngeal. Vagus, there's going to be palpitations because it's going to our heart. And the uvula, this is really important, it's deviated away from that affected side. So if there's a lesion to the right, my uvula will deviate to the left. Spinal accessory goes to the sternocleidomastoid, which is in the neck, and the trapezius that we've already talked about in block 1, and that's going to cause shoulder drop. Hypoglossal, it's going to the muscles of the neck and to the tongue, so the tongue's going to deviate toward the affected side. So here's some of these cranial nerves coming out from the base. Here are them located on the brain, and we've already talked about 3 and 6. So let's talk about cranial nerve 5. So this is our trigeminal nerve. Trigeminal. So tri means 3. So there's 3 branches. So V1 is going through this superior orbital fissure, standing. So standing room only. It's providing sensation only. R is room. It's going foramen rotundum. And so V2 is traveling in that PT fossa through foramen rotundum. And it's also only sensory. V3 is a little bit different. It's sensory, but it's also motor, and it's going through foramen ovale. So let's look at this picture down here. V1 is traveling to the forehead and eyes, and then it's also all the way down the nose. It's important to know that it's going down the nose because that was important again in the danger triangle. So we talked about V1 and V2 being affected, but if somebody lost sensation to the top of their nose, it's important to know that's V1 and not V2. V2 is getting the cheeks, the outer nares, and then the maxilla and upper lip, but it's not getting that nose. V3 is going to be the mandible, and it's going all the way up to the ear. So we're going to look later on at some parasympathetics to the head, but I just wanted you to be able to see V1, V2, V3, and the fact that some other cranial nerves are going to travel along with it. So V1 is ophthalmic, it's going to our eyes. 2 is maxillary, going to our maxilla, and then V3 is mandibular. Infratemporal fossa, the IT fossa, that's going to be V3 is traveling through it. So the roof of the IT fossa is going to be the temporalis muscle on the lateral side, the sphenoid, the greater wing, and then which is more medially, and then the foramen ovale. Again, V3 travels through it, and then foramen spinosum, which the middle meningeal artery travels through it, and then petrotympanic fissure, which chorda tympani travels through. Laterally, we're going to have that ramus of the mandible that's been cut in this picture. And then medially, we're going to have the pterygoid process and then the pterygomaxillary fissure, which is the door to the PT fossa. Anterior is going to be the maxilla, and then posterior and the floor is going to be open. So the contents are going to be, again, V3, as well as the maxillary artery. The maxillary artery is going to go ahead and travel through the IT fossa into the PT fossa. And then we're going to have these muscles, temporalis, medial, and lateral pterygoid muscles. And then right here also is the sphenomandibular ligament running from the sphenoid to the lingua of the mandible. Okay, so here's the muscles of mastication. So mastication is like being able to eat and chew. So all of these muscles except the masseter are in the IT fossa. So the masseter is on the outside because remember we said back one page, the lateral aspect of the IT fossa is the ramus of the mandible. But right here you can see that it is located on the outer portion of the mandible up to our zygomatic arch. So the masseter, temporalis, and medial pterygoid, they're all going to elevate that mandible. The only one that can open the mandible is the lateral pterygoid, and that one is really important. Another important feature is temporalis. Of course, it's coming from the temporal fossa. It makes sense. But it is attaching down to the coronoid process right here on the mandible, where that lateral pterygoid is going to the condyle. So they like to know that you know the difference between condyle and coronoid. Since it's got a fancy name, make sure that you know temporalis attaches to the coronoid process. So let's look at these attachments again. Lateral pterygoid at the condyle, temporalis at the coronoid process, and the masseter and medial pterygoid are going to be the ramus. Okay, let's look at it on a CT scan. So 3, we've got medial pterygoid. This is going in between the medial and lateral pterygoid plates. So here's the medial, here's the lateral. Right here, number 4 is going to be the lateral pterygoid muscle. It's going to be on the outside portion of this lateral pterygoid plate. Looking at a transverse CT, we can see right here, here's the hard palate of the mouth that kind of gets you oriented. Right here too, that's going to be the ramus of the mandible. And then number 3 is going to be that masseter muscle, remember, outside of the IT fossa. Then number 4 right here is going to be that styloid process. Right here's the mastoid process. And you find those usually in OPP. I remember finding those in our first lab that we had. Number 6 is going to be the internal jugular vein. It's bright white because it's got blood. And right here is number 7. That's the lateral pterygoid plate. And so probably the medial would be here. So we've got the lateral and medial pterygoid. Okay, so here are the mandibular branches of V3. So for sensory, we've got auriculotemporal, buccal, inferior alveolar, and lingual. And then for motor, we have mylohyoid. And so we'll start with motor because it's only one thing. So it's going to be the nerve that's going to the mylohyoid as well as the anterior belly of the digastric muscle. And so you're going to learn those when we talk about the neck, but they're going to be really close together, so you can think that they're both going to be innervated by mylohyoid. And if we look in this picture, you can see that mylohyoid nerve coming right off of this inferior alveolar. And then that inferior alveolar, they're running right beside each other. They almost look like they're running together. And that inferior alveolar continues on down under that mandible. So the auriculotemporal, if you think about it, auriculo, that kind of sounds like the ear. Temporal, it sounds like the temporal region. So it's going to provide sensation of the skin around the ear to the more anterior portion of the ear. And it's kind of unique and cool because it splits right around the middle meningeal artery. Remember, we said the middle meningeal was really important in the epidural hematoma. So if somebody gets hit on the side of the head and has an epidural hematoma, it's going to be due to that rupture of the middle meningeal artery. And then also there's going to be postganglionic fibers of the lateral petrosal nerve and cranial nerve 9 that's going to travel from that otic ganglion with the auriculotemporal nerve, cranial nerve V3. So let's look at that, and it's just hitching a ride on there. So we've got the glossopharyngeal nerve, cranial nerve 9. It's traveling. Here's our tympanic branch going to our tympanic plexus. It becomes the lesser petrosal nerve, and then it's synapsing at the otic ganglion. And then it continues on to the parotid salivary gland, but it's hitching that ride on auriculotemporal nerve. Buccal is going to be going to our cheek. So anytime you see buccal, that means cheek. Then inferior alveolar is going to provide sensation to the lower teeth. So a dentist, for example, might numb that inferior alveolar nerve and provide a block to that to do dental work on the lower teeth. And then it becomes that mental nerve after exiting the mental foramen. And that's what was on one of those slides at the beginning. We said that we would talk about what comes through the mental foramen, and that is the mental nerve that came from inferior alveolar. The lingual nerve is going to be sensory to the anterior 2/3 of the tongue. And then the chorda tympani, which is the taste as well as parasympathetics from cranial nerve 7, is going to join to provide taste to the anterior 2/3 of the tongue and the secromotor and mandibular and sublingual glands. And so we'll look at that facial nerve later on. So the temporomandibular joint, V3, is going to be, I think of like TMJ syndrome. So some people have a hard time opening and closing their mouth, and it makes a crunching noise. So this is because of this joint. It's like a normal joint in the body. It has a meniscus and a disc. So it's similar to a joint like, let's say, your knee. The joint capsule sensation is innervated by auriculotemporal. Remember, we said auriculotemporal is going to that ear. So if a person has TMJ syndrome, they may have ear pain as well. So dislocation may occur when somebody is like yawning or there's a blow to the chin and it pushes that mandible past the tubercle anteriorly and that jaw is stuck open if the dislocation is bilateral. So to reduce it, they have to pull down on that on the lower molars and push that jaw posteriorly. So let's look at these muscles. So here is the temporalis. Here's masseter. Here's that auriculotemporal that goes around the middle meningeal. Here's that nerve, teminohyoid. It's super tiny. Here's the mental nerve. And here's that, in that picture, we can also see the inferior alveolar and then the lingual nerve as well. And then over here, we can see the medial pterygoid, and here's the lateral. So that maxillary artery runs through the IT and PT fossa, like I said, and it's coming from the external carotid artery, passing under the inferior head of the lateral pterygoid muscle. And so here's just a look at all of that, and if this speaks to you more, that's great. It's a little bit busy, but it definitely goes through all of these things that we've talked about so far in the blue. Okay, abducens, that's going to be cranial nerve 6. So like we said, it can cause that medial strabismus. So facial nerve, cranial nerve 7. So it's got a bunch of functions. It supplies the muscles of facial expression, as well as the posterior belly of the digastric muscle, the stylohyoid, and the stapedius. It also gives visceral motor, so parasympathetic innervation to the lacrimal, submandibular, and sublingual glands, and the mucous membranes of the nasopharynx, hard and soft palate. Also to the special sensory, it's providing taste sensation from the anterior 2/3 of the tongue, and then general sensation as well of the skin of the concha and the auricle and a small area behind the ear. So let's look at all of the branches of cranial nerve 7, which would be facial. So let's start first off with red, and that's going to be the sensation. So this is our special sensory. It's coming down through the internal auditory meatus through this facial canal, and it's going to synapse at the geniculate ganglion. It's going to continue on down and start traveling to our submandibular ganglion, and it's joining up with the parasympathetics to be called the chorda tympani. It's providing taste to the anterior 2/3 of the tongue. So let's go to white, the parasympathetics. We already said that it's going down through the internal auditory meatus, traveling to go with the sensation and be called the chorda tympani. It continues on to that submandibular gland, providing that secretomotor function to the gland, and going to the submandibular gland and sublingual gland. The other parasympathetic is coming through that internal auditory meatus through the facial canal and coming out as the greater petrosal nerve. That's going to be traveling through the pterygoid canal with that deep petrosal nerve, and it's going to synapse at the pterygopalatine ganglion. So let's go to the motor now. So the motor's in yellow, so we go through the internal auditory meatus, and we're going to give off a branch, which is a nerve to the stapedius in our ear. We continue on down through that facial canal and out the stylomastoid foramen. We're going to give a branch to the posterior auricular, which is the posterior auricular nerve, and then also the nerve to the stylohyoid and posterior digastric, which are neck muscles. We continue on to give the branches to the muscles of facial expression. So we've got temporal, zygomatic, buccal, mandibular, and cervical. So that's 2 Zanzibar bimotor car. The only things to talk about are what's in blue, and these nerves do not come from cranial nerve 7, but they do travel with it. So that deep petrosal nerve is coming from the internal carotid plexus, and it's going to be sympathetic nerve that travels up into the superior cervical ganglion and goes with the greater petrosals through that PT canal to the to synapse at the pterygopalatine ganglion to the lacrimal gland. And we're going to talk more about that in a little bit when we talk about the lacrimal gland. The lingual nerve is coming from V3, and it's providing general sense to the anterior 2/3 of the tongue, and that's traveling with that chorda tympani. So summary of the function, the greater petrosal nerve is preganglionic parasympathetic to the pterygopalatine ganglion, and it's entering that pterygoid canal to make up the nerve of the pterygoid canal. The nerve testopedius is motor. Chorda tympani is providing taste to the anterior 2/3 of the tongue, and parasympathetics to glands in the mouth via the submandibular ganglion. Branches to muscles of facial expression are going to be that two Zanzibar bimotor car, so temporal, zygomatic, buccal, marginal mandibular, and cervical. So here are the nerves. We've got the PT ganglion, and right here is that chorda tympani traveling with lingual nerve. So here's our branches of facial expression. We've got temporal, here's buccal, here's mandibular, here's zygomatic, and here's cervical. And a way you can do it is just putting your hand on your face. You kind of have to reach around your head. So if you take your right arm, you have to touch your left face around the back of your head. But you can do this, and it can help you. So temporal is going to the forehead, zygomatic going across that zygomatic arch, buccal to the cheek, mandibular, marginal mandibular to our mandible, and cervical to our neck. So here are the muscles of facial expression, and it's important to remember some of these because I know there's a lot of muscles, but a lot of them will kind of tell you where they're going and what they're doing. So frontalis is going to right here to the frontal portion of our face and to wrinkle our forehead. Corrugator supercilii. So super, silly deals with the eye. So it's above the eye, so it's moving the eyebrows down immediately. So it's like the 11 shape if you're making wrinkles. Procerus is wrinkling that nose. So that one's a little bit hard, but some of these sound pretty similar. So orbicularis oculi, it's orbiting the oculi, so the eye, closing the eyelids. Make sure that you don't get that one confused with orbicularis oris. Oris means mouth, so it's closing and protruding the lips. So the zygomatics are pulling the corners of the lips up and out. So buccinator, or just pulling it up. Buccinator is going to our cheeks, so it's pulling the corner of our mouth backwards and compressing the cheek against our teeth. So it's helping with our smiling. Nasalis, flaring nostrils. Risorius, that one's a hard one for people to remember, so I would try to like put it on flashcards or something, but it's pulling the corners of the mouth laterally. Levator labii superioris, superior. It's going up. Labii, mouth. So, and lips. So it's elevating the upper lip. And so just go through these and try to remember the names of them. So here's it labeled again. Here's that submandibular gland, which is kind of cool. Depressor anguli ori, depressor labii inferioris. Anguli is on an angle. Depressor, it's going down. Zygomatic major, orbicularis oris. Zygomatic minor, levator labii superioris, frontalis, orbicularis oculi. And right here is that parotid duct going right through here, and here's our buccinator. And it's deep to that buccal fat pad, and it's pierced by that parotid duct, so that can be a way that you can remember it. And motor innervation is facial. Nerve, the buccal branch, and then the sensory innervation is going to be cranial nerve V3. And then looking right here, you can see the facial artery, and it's curlicue or tortuous. So knowing the facial nerve is really to be able to answer lesion questions. So if I were to lesion right here, I'm just lesioning out the branches of facial expression. So I'm going to have an asymmetric smile, trouble blinking, drooling. So it's just getting motor. If I lesion up farther, like right here at the geniculate ganglion, I'm going to, or close to the geniculate ganglion up in the facial canal, I'm going to be affecting all of the branches right here of the facial nerve. So there's not going to be parasympathetic involvement or motor or sensory. So they're going to have decreased tear production, loss of taste to anterior 2/3 of the tongue, and then also sensitivity of sound because that nerve's just stapedius. If I lesion or have, let's say, a tumor within the internal auditory meatus, there's going to be pressure on cranial nerve 7 and 8. So you're going to have all of those symptoms that we just talked about, plus you're going to also have problems with hearing as well, since that's what cranial nerve 8 does. If we lesion just the lingual nerve, we're going to have all sensation to cranial nerve 7, but however, we're not going to have sensation to the anterior 2/3 of the tongue. Remember, lingual nerve came from V3. And then chorda tympani, if we lesion it, we're not going to have taste to anterior 2/3 of the tongue and decreased salivation, but we'll still be able to sense. However, if it's a lesion that's farther down and it's cutting chorda tympani and lingual nerve, you're not going to have any taste. You're not going to have any sensation, and then also you're going to have decreased salivation. The lesser petrosal nerve is going to be cranial nerve 9, and we had talked about that just a little bit. So preganglionic parasympathetics from cranial nerve 9 give off the tympanic nerve, forming the tympanic plexus in the middle ear. It's re-entering the skull via the jugular foramen, which is now called the lesser petrosal nerve, and it's lying in the middle cranial fossa and exiting the foramino-valley. The preganglionic synapse at the oda ganglion found at the medial to cranial nerve V3, and it's going to innervate those parotid glands. So here's some clinical correlates. So if somebody has abnormal connections, so that develop one of these things are called crocodile tear syndrome. So if the person normally salivates, so let's say that they smell something really good and they're hungry, and instead of salivating, they start crying. And then Frey syndrome, you can see that this patient has this, had a surgery of some sort right here, so maybe they cut cranial nerve 9, and so when they usually salivate, their face is going to flush and sweat. Here is just for you. You can print it out and try to label everything, and the answers are over here. And this can just be an activity to help you study.